Hello and welcome. This is the Lancet Maternal Health Series, Global Research and Evidence MOOC, and this is our live Q&A, so thank you for joining us. We have an hour of jam-packed maternal health facts, figures and questions, and we're very much looking forward to your participation. If you would like to post a question, you can do it on step 2.12 in the comments and discussion area. And you can also post questions on Twitter using hashtag #FLMaternalHealth. We'll be taking questions throughout the next hour, and we also have questions that learners have already posted. We're very fortunate today that we have a number of co-authors from the series and all spread geographically across the globe. So in San Francisco, we have Professor Suellen Miller, who was the person that led the paper on guidelines, paper 2 of the series, and she's joining us from there. We also have the lead educators and principal investigators from the series and the course, and that is Professor Oona Campbell from the London School of Hygiene and Tropical Medicine, who is joining us from Beirut, and we also have Professor Wendy Graham, who is joining us from Edinburgh. In the studio today, we also have one of the co-authors on Oona's paper, which is Dr. Lenka Benova, who is an assistant professor at the London School of Hygiene and Tropical Medicine, and myself, Adrienne Testa, who some of you will know from interjecting and mentoring and replying to your responses on the MOOC. So thank you for joining us today, and we will start to kick off with some of the questions that we have. Suellen, this one's for you. I'm not a health professional, and I'd like to know more about how women and individuals seeking and receiving care can do more to ensure they receive high quality care. And that's a question from Michaela.
Right, and we were going to combine that with another question, the question following that.
Do you want to answer both together?
Can you hear me?
Yes. Okay, so there's a second question.
Right, which I think it follows on, and I'd like to answer them both together.
Okay, so I'll just read out the second one, which is, what role do women who are accessing maternal health care have in ensuring they receive quality care? And what more can women do at an individual level to encourage progress in quality care outcomes?
Great. Hello, everyone. It's so nice to see you this morning, this evening, this afternoon, wherever you are. It's quite early in the morning here in California. Thank you for those questions. They're very, very good. I would like to start answering these questions by making sure that we never blame women for not receiving the quality of care they deserve. That putting an emphasis on the woman as an individual has to come in both directions. To know what they deserve, women have to know their own rights. And where do women know their own rights? Not everywhere, certainly. So there needs to be education of what their rights are and consciousness raising, as we used to call it in the 70s, or sensitization. And this can come in the form, many, many forms. For example, there's a form of care called group antenatal care, where women get together. There's a midwife or midwives sort of facilitating this care. Women learn how to take their own blood pressures or each other's blood pressures and check their urine and measure the growth of each other's babies. And they share a lot of information, including what respectful care is, what is unacceptable care, and how to go about asking for it. So there are organizations such as the Human Rights in Childbirth group, which recognize what disrespectful and abusive care is, and with activists, doulas, educators, being sure that compassionate, people-centered care becomes an accepted norm. One of the groups that I'll mention is the White Ribbon Alliance, and they have 14 national organizations under their umbrella, which is demanding the right to a safe birth, so that women in many countries, from Afghanistan to Zimbabwe, are able to learn what their rights are and then to be able to, as a group, demand that. And that can give a lot more credence than one woman speaking alone. That's not to say that one woman speaking alone doesn't actually work, but she has to have the knowledge to know that she has the right to demand that. There's another group, Maternity Action in the United Kingdom, which give rights to especially immigrants and migrants who tend to really receive either, as we've talked before, too much too soon or too little too late. An Alliance for Women's Health that puts emphasis on low intervention birth. An International Mother, Baby, Childbirth Initiative, which is working with FIGO, the International Federation of Obstetrics and Gynecology, to actually have mother-friendly facilities. These facilities are going to be certified as mother-baby friendly, and among their demands are that there are no bribes, there's no holding women if they can't pay their bills, and no obstetrical violence. And I think that obstetrical violence or disrespect and abuse in childbirth, or the reverse, respectful care, has now become an international movement. And this has come from many places. Venezuela, Argentina actually have laws against obstetric violence. But that means that, again, women have to be aware of those laws and aware of those rights. And I think I can take questions about this or ask Oona or Wendy if they have any additions to those organizations' laws and other ways that individuals that are pregnant or not pregnant, civil society can work to be sure that women receive quality care. Thank you.
Well, maybe, I mean, one thing I could add is that certainly when we launched the Lancet Maternal Health Series in India, that was in the context of a conference that was around human rights and human rights for women delivering and giving birth. And also I saw that some of the participants on the course are, for example, there was a participant from India who was actually involved in training and giving information to women about their rights and about what normal childbirth was. And I think it's really encouraging to see that there are such initiatives.
Okay, thank you, Suellen, and thank you, Oona. We'll move on to our next question, and this is for Lenka, who's in the studio with us. So the question is from Manuela, and it's: maternal health in urban areas is an increasing concern in sub-Saharan Africa, following rapid urbanisation. Could you tell us more about the gaps and why they're greater?
Yes, thank you to Manuela for this question, and thank you for all the participants for engaging very broadly with the topic of inequality following my lecture, but also the other topics on the course. And I wanted to say that each country tends to see somewhat a different pattern of exclusion in urban areas, and this is largely because urban areas are undergoing such a dynamic shift and change over time, and so we really have to understand things very locally in regard to urban areas, globally, but in sub-Saharan Africa in particular, due to migration and building of slums and townships and so on. What are some of the reasons for large urban gaps in maternal care in sub-Saharan Africa? These could vary by context, of course. They could be geographical. So, even though women are living in what might be seen as close proximity to care, they might not be able to get there. And this could be due to their location in slums or areas that are actually have very low transport links to the center of the cities where facilities tend to be located, or high-level facilities tend to be located. There could be cultural factors. There's increasing evidence that poor women in rural areas are experiencing discrimination They might be receiving low quality of care in the same facilities where richer or wealthier women are receiving good quality care. And this is obviously a large issue and might be driving some of these poor women toward low-level private providers, where not only are they experiencing financial burdens, but again, experiencing poor quality of care. What we do know, on the other hand, is that in context, in countries where efforts have been made to improve this situation, there has been a large improvement in the gaps between largely the poor and the wealthier in urban areas. And some of those countries are, for example, Namibia. In other regions of the globe, Colombia and Vietnam stand out as such context. And how has this been done? Of course, one must understand the reasons for these inequalities locally. These must be addressed. But also, we need to understand the reason for marginalization, whether it is poverty in itself or geographic location of certain populations, or their perhaps cultural and ethnic differences, language barriers. So the marginalization is really important and needs to be addressed not only country by country, but almost city by city. I don't know if anybody wanted to add from our colleagues, but that I think sums up the question, sums up the answer for Manuela.
Okay, does anyone from the panel have anything further to add? No, okay. Oh, Suellen does. Okay, Suellen.
Yes, my hand's up. Okay, thanks. It was very interesting, and I've been working for quite some time, 40 years, on respectful care. What I've discovered over time, and especially working on the respectful care section of the Reproductive Health Journal as an editor, is that every place that there's a difference between providers or the administrators or decision makers of a system and the women, that difference results in unequal care. It could be language inability and lack of understanding of cultural differences in what is expected in childbirth, ethnicity, certainly between economic groups. Whenever there's this difference, it seems that the marginalized women receive a different kind of care, and it may be more abusive, it may be more of too much too soon. Surprisingly, it's not just that they get a lack of care, but they may be over-medicalized because of fear, and a fear of being sued, the fear that the doctors in India have of being beat up if things go wrong. So it leads to too many C-sections, too many inductions, too much care, as are seen in the high-income countries. But even the countries we look up to, such as Sweden, Denmark, Finland, places where access to care is good, these differentials to the migrant populations are also very, very different care than what is received by the mainstream population.
Thank you very much, Suellen. Thank you for that addition. Okay, we'll be going to another question now, and this one is for Oona. And the question is, what economic influences impact women accessing referral of women to high-level facilities?
Well, economic barriers are very important in terms of maternity care, and there's been a lot of attention paid to the economic obstacles faced by women when they want to access care for routine birth and for emergency complications. And this is partly about the actual costs they have to pay for the care, but also about the uncertainty of what they're expected to have to pay for care. But one of the other important areas is really the costs of transport, which can be very high in some contexts, particularly if women are very remote from services, or if they're trying to access services, for example, in the evening. So if a woman goes into labor at night, it might be very difficult to certainly get public forms of transport, but even engaging in a private means of getting to services can be really, really very high. Now, some countries have started to put in place initiatives that acknowledge these costs. So, for example, in India, There's a 108 ambulance service in many of the states, and this provides subsidized transport for women. It's free of charge transport for women, pick them up from their homes and take them to close by facilities for delivery care. And they also will transfer women between facilities who need inter-facility transfers. These kinds of issues also apply to maternity waiting homes. So we know that we've talked a little bit about how one option is for women to move before they're in labor to be close to the place they want to deliver in, and that's to reduce the traveling times when they actually go into labor. But of course, then you also need to cover the length of time that you're in the maternity waiting home, so who's going to pay for that care, but also the opportunity cost of anybody who's going to accompany the woman. So there might be lost wages in that respect. So the costs involved in referral, in transport, in moving to a maternity waiting home can often be very large barriers to women accessing skilled care at birth.
Thank you, Oona. I mean, I think it's really striking. I've been very fortunate to work in Ethiopia, and Ethiopia is one of those countries that has really tried maternity waiting homes and has been exploring them more recently as well. And at the same time, the place I'm linked with in the United Kingdom, which is the Aberdeen Maternity Hospital, has a waiting home as well. And the interesting thing is that in terms of these barriers to use or access, one of the things that's striking is sort of speaking to women in those very different contexts is this issue of what to do about their children. And it's sort of partly an economic cost, because are they going to need to pay for childcare, which might be true in a United Kingdom setting. But it's also just the whole issue of caring for those children. If they're being asked to come down 6 weeks in advance or whatever it might be, that real barrier of the support to those children, and that will be true in Ethiopia and in somewhere like Scotland as well. So I think, as Oona says, these opportunity costs, they sound like they're financial, but you need to unpack. You always need to go behind what seems like the immediate cost to look for those deeper ones. So childcare cover. Thank you.
Thank you, Oona, and thank you, Wendy. So actually, we'll be going back to Wendy for our next question, which is around the burden of maternal health. So this is a question from Priscilla, who says, I've not heard of the concept of obstetric transition, but it makes a lot of sense. I wonder whether we will need to quote maternal morbidity figures more in the future to properly reflect the impact of this change. Wendy, would you like to respond to that question from Priscilla?
Yes, thank you, Priscilla. And it's interesting looking at the comments on the platform that show that many people like this idea. They commented quite a lot about the obstetric transition as being something new and quite intriguing. I think it's important to know that this actual transition is building on a much older concept, which was sort of launched in the 1970s, and that's what's called the epidemiological transition. And that basically is about, over time, the pattern of burden, health burden, be mortality or morbidity, shifts over time from an infectious or communicable disease profile dominantly to a non-communicable profile. And the sort of feeling was that those sort of follow a series of phases. I think the interesting thing what's happening now in low-income countries and in other parts of the world is that we're seeing not only a shift to increased diseases, but there's still a communicable burden left behind. And there's also the sort of what you might call the obstetric causes as well. So if you look at, for example, women presenting these days, not only might they present with a chronic underlying morbidity, they might also have an obstetric morbidity. And it's this complexity of cases that I think is a really key thing that is mostly, in particular, a challenge to services. This issue about understanding how the risk profile of women coming into facilities, delivering at home, that burden, that profile is changing. And it's changing partly because of this underlying shift of more women surviving perhaps chronic disease going on to entity that period. But there's other things that are driving change, like age at first birth. So if you look and see across the world, particularly in high-income countries, take Spain, for example, over 30% of women are now having their first birth age 35. Now, that's 35 isn't very old, really. types of complications increase, both obstetric complications and other chronic morbidities. So to me, it's this crux of understanding that the women that are coming into services that need safe, stable, effective care, that profile is changing. And the most important test is services, both provision of service and training, research, and in-service providers needs to catch up with this. This is not just something that's happening only in high-income countries. See more NCDs in high-income countries, featuring in women of reproductive age and pregnant women, but it's happening everywhere now. So it's really, really important that we link up this concept. It is a concept, it's an idea that over time patterns of diseases change. And if you look at paper 6 in the Lancet series, the paper led by Marge Kabinski, she has a very interesting panel where she breaks it down into the different phases of the obstetric transition. But the really, really key thing is that we need to start to prepare in curricula, in pre-service, in-service training, to recognize that these patterns of illness or patterns of potential risks that affect women when they're coming into pregnancy and childbirth, those are changing. That's not to over-medicalize, and I think that's the real challenge, is that some of these morbidities can be managed well. These are different roles in antenatal care, early detection, preconception counselling. So it's not that we want to see a transition into more over-medicalisation, but it is about recognising that this pattern is changing. Services need to change. If you want to meet the needs of women and their expectations, we've really got to get ahead of this very, very serious challenge. Thank you. I don't know if Oona or Suellen would like to add to that.
Okay, so thank you very much for that, Wendy and Suellen. And that brings us on quite neatly talking about over-medicalisation. Question for Suellen, which is related to the too much too soon theme in her paper in the Lancet series, and also the themes in the steps of this week's part of the course. So this one's for you, Suellen. What are the most common causes of caesarean sections that are too much too soon?
So what I'd like to talk about are the various reasons why women have caesarean sections or caesarean births that are too much too soon. And two of the main causes, the most frequent causes of what we would call an unnecessary or not for medical indication causes are something that is labeled failure to progress or fetal pelvic disproportion. Okay, so those two things, which can often happen in a first birth, are artificial. They really, if you really look at populations, they don't occur that often. Not to say that there isn't something called obstructed labor where the baby really is too big for the pelvis, but this failure to progress is now being attacked by clinicians, providers, as well as communities and women. It's so under fire right now that they're actually, the American College of OBGYN, WHO, the International Federation of Gynecologists and Obstetricians, as well as the International Congress of Midwives, have all agreed that the definition of active labor should start much later. So it was 4 centimeters where you would say this is where labor begins. And now they're saying 6 centimeters. So we're sure the woman is really in active labor before we begin intervening because she's been in labor such a long time. So this is quite a change, and it's now being found in very high quality guidelines. There's a movement to prevent the first C-section. And that will do 2 things. It will decrease the level or the risk of too many first C-sections, but it will also move into the next cause of caesarean section, which is once a C-section, always a C-section. So that increasing vaginal births after caesarean, what's called a trial of labor for those women, and using the same quality guidelines to look at her progress will decrease the other big cause. So I think that this is something that has been happening far too long. And as we saw in paper 2, the highest rates are in the middle income countries. Brazil, Dominican Republic have rates that are so high, 50, 60%, and in the private sector even higher, that these indications will change. The other thing is, another intervention is inducing, and something called a failed induction. Again, with time limits that do not represent physiological birth, so that not giving the woman time, also not having her and her family come to a facility too early so that it seems that it's been so much longer. So I think those are the reasons mainly for these unnecessary cesarean deliveries, and trying to get the first delivery by vaginal delivery will take care of so many of these other unnecessary C-sections.
So that brings us on nicely to talk about adaptations in the health system to improve quality of care, particularly addressing things like the impacts of poor quality care leading to too much too soon. So this is a question for Oona, and it's from Mauricio. In terms of staffing and workforce planning, is there evidence on how to adapt the health system in countries where midwives are practically non-existent and almost all maternal obstetric care is given by gynecologists? Should planning focus on midwifery?
Well, I think the first thing to say is that it's no secret for those of you that read the series carefully or who have read earlier series like the Lancet Midwifery series, that many of us who've looked at the evidence around maternity care, if we were designing a country's health system from scratch, I think we would all opt for a health system where midwives are at the core of providing maternity care. And we know that many of the high-income countries that have the best maternal and neonatal health outcomes are systems that are organized around the primary caregiver for women being midwives. Now, that's a very different question from the question of, well, what do you do if you have a different kind of healthcare system? You know, if you have a system where most deliveries are done by obstetricians or by gynecologists. And I think here the first answer is, I don't think, at least as far as I'm aware, I don't know of a system that's shifted from having a majority doctors or the vast majority of deliveries led by doctors to a system where they're done by midwives. So I'm not aware of any examples, but what I'm certainly aware of are that many countries have recognized the importance of midwifery care and are now making concerted efforts to try to build a cadre. And I think, doctors are very powerful in society, and I wouldn't recommend that any government try to kick them out of their jobs overnight and replace them with midwives. I think we have experiences from Brazil, from Bangladesh, where doctors can be major players in opposing political parties and political power. But what I think you can do is to start thinking about making a shift in the kind of health workforce. And I think those of you that heard Jim Campbell's lecture about the staffing and the human resources in health can learn and think about how to plan for a future that might be midwives. So, for example, I know in Mexico, they very recently started a midwifery cadre, and they're starting to train midwives. That's a system that's primarily led by obstetricians. Similarly, in Canada, where the vast majority of deliveries are done by obstetricians, there's now a huge interest in increasing the proportions of deliveries done by midwives. But I think also we always have to remember that these are health systems issues, so it's not just about training the midwives, but you need to think about things like, how is the financing happening? So, for example, in some settings, insurance companies won't pay for deliveries attended by midwives. So you need to, it's not just about training the midwives, but you need to think about, well, how are you going to start getting them to do a bigger deliveries, etc. The other thing is, I think another really useful piece of evidence to think about is there's certainly in high-income countries huge concerns about the costs of delivery care, and usually deliveries attended by midwives are less expensive, both because unfortunately midwives tend to less, but also because they're much less likely to undertake unnecessary interventions. So I think I don't think I can directly answer the question by saying, here's an example of a country that's completely shifted from being doctor-led to midwifery-led, but there are certainly many examples where countries are trying to grow the midwifery cadre, and I think it's best done looking to the future and doing it strategically, thinking about the money, the payments, the training, the quality assurance, etc. So it's not just about let's train some midwives. Thank you.
Thank you, Oona. Suellen, Lenka or Wendy, would you like to add anything to that?
Yes, I guess because the platform has been built on the Lancet series on maternal health, I'm sure many of the readers will know about the Lancet Midwifery series. And I think it's really important to look at the other series as well, and the State of the World's Midwives, which is also another amazing resource. The State of the World's Midwives talks a lot about different case studies of countries that have got different models, some supported by UNFPA with the Accelerated Midwifery Training Programme. But yes, our own Lancet series, we really struggled with the number of words we were allowed to use, so we can't do justice to everything. So do consult the Lancet series on midwifery as well.
Thank you very much, Wendy. Okay, so we have another question, and this one is for Lenka. And this comes from Lisa. Is there a classification of what determines a hospital, a clinic, or a health facility? And if having access to these services really does equate to adequate maternal care during labour and delivery?
Thank you, Lisa, for the question, and the quick response is no and no. And I think I'll just get into the theme, thinking through two lenses. One would be the health systems lens, and the other perspective would be, what do we know about women deliver, and how do we know where women deliver? So I'll start with the health systems perspective. And here, all countries have a system where they designate facility of certain levels, of certain names. So whether it's a health post and a health clinic and a health center and a hospital or a teaching hospital and a referral hospital or a national hospital, every country and Ministry of Health knows which provider is which designation. The very important question that you raised, Lisa, was, do they actually provide the types of services that are expected of them? And for this, countries can either sort of request a census of health facilities or do a survey, such as the service provision assessment or other surveys, to check on some basic core functions that these facilities need to have in place to be able to provide maternal services. And these we call signal functions, so emergency obstetric signal functions, and they can compare. So what is a health center supposed to be able to do? What kinds of staffing, levels of staff, equipment, and provisions do they need to have on site 24 hours a day or on call to be able to provide the types of services that are expected of them? And I think one important learning that we have found looking through these surveys and census of health facilities is there is a large shortfall in these capabilities, which is important to be highlighted and tackled. And another stream of thinking that has expanded from these signal functions for obstetric care is to look at other reproductive health services, such as provision of family planning, post-abortion care, abortion care, and services following sexual violence or intimate partner violence. The second perspective I wanted to talk about was, well, how do we know about where women deliver? In most low and middle income countries, we use surveys of women who have had childbirth recently. And so we rely on them to tell us where they delivered. And these questions usually say, where was, you know, your most recently born child delivered? And the woman will say, you know, it was in a health center or a health facility. She might know the name of the hospital, and then the enumerator will circle the facility type. And what we do know about these surveys is that actually women can recall fairly accurately the level of facility where they delivered. It might be a little bit complicated in some countries where, for example, facilities are operating, facilities are owned, let's say, by a church or a faith-based organization, but they outwardly seem as if they are governmental facilities. But that's another topic that doesn't necessarily relate to the level of services they're supposed to provide, but to the ownership and type of management that they are under.
So we'll go for one final question, and then we'll have a little bit of time for reflections and discussion amongst the panel. So this question is for Wendy, and it comes from Sanjeev, and it very much speaks to where the course goes next week. So the theme of the course in week 3 is the future of maternal health and looking at maternal health in the Sustainable Development Goal era. So Sanjeev's question is, how were the SDGs developed in relation to maternal health, and how is this related to the mortality, maternal mortality ratio?
Thank you very much, Sanjeev. I mean, without sort of stealing the thunder of next week, when, as Adrienne says, there's going to be much more discussion about future. As you can imagine, we've gone from an era of an MDG that was dedicated to improving maternal health with a very specific target of 75% reduction in maternal mortality. So that era kept maternal mortality very high up on the agenda and a focus on improvements. So as you can imagine, as MDGs came to an end and the SDG era emerged, there was some concern about the unfinished agenda in maternal mortality reduction and improving maternal health, whether in losing that MDG, we would lose sight of that priority. And so although there is only one direct health SDG, that's SDG 3, which is on good health and well-being, below that overall goal, there are targets that are set, and there are targets that are certainly set for maternal mortality. And as I said, the main reason for ensuring that maternal mortality had a presence in the health targets is to make sure those countries that were off target, that didn't achieve MDG 5A, are given extra support in going forward so they can achieve more rapid, accelerated progress. And there's a strategy called Ending Preventable Maternal Mortality. It's a strategy that talks about accelerating progress and particularly supporting those countries that achieve less than they hoped for in the MDG era. So that strategy, Ending Preventable Maternal Mortality, talks about different types of prioritization depending on the remaining levels of maternal mortality and how to accelerate. And I think it's really important in the SDG era that we didn't see so quite well connected in the MDG era, is that the strategy ending preventable maternal mortality also linked up with a strategy looking at the newborn and stillbirths as well, because those adverse outcomes, the deaths, the stillbirths, the newborn deaths, the maternal deaths, are very close interlinked. So if you're going to accelerate progress for reducing maternal mortality, you are going to have an impact on newborn mortality, and there's synergies there. The maternal mortality ratio, which I have to say is not one of my favourite indicators, there are other more sensitive ways of measuring maternal mortality, but that indicator, that's maternal deaths, 100,000 live births, lives on in the SDG era. And there are two types of targets. There's a target of a global target by 2030 of 70 maternal deaths per 100,000 live births, but it's well recognised that some countries, that is a very, very tall order. If you're in somewhere like Ethiopia with an MMR around 600 or whatever you believe the latest estimate is, getting to 70 is very tall order.
So for the next short part of this live Q&A, we're going to move to reflections amongst the panellists on the Lancet Maternal Health Series itself, on the course, on the MOOC, and the engagement with learners that we've had last week and this week, and also the questions from here. So if I could go to Wendy first, for some final reflections.
Yes, no, I think this has been one of the most exciting things that I've had an opportunity to be engaged with for a very long while, I have to say. And I think the thing that excites me the most is this opportunity to reach out to real rounded individuals presenting a vast range of experience. So I can sit here in Scotland as it gets darker here and really link up with individuals who are speaking from very different contexts. In all the years I've worked on maternal health, this issue of concepts is so diverse. You need to find an effective way to hear those perspectives from those very different settings. And it seems to me this learning platform has been a very efficient way of hearing about this diversity, the diversity that I think is only going to increase. So it's been a fantastic experience, and we look forward to carrying on next week.
Fantastic, thank you, Wendy. And if we could hear from Suellen, please.
I had to get my microphone on. I feel the same way. For me, this is very new, having involvement in a course that reaches so far and to so many people. I've had conference calls where there have been people from all over the world at odd hours of the day and night for me, but this is amazing, and being able to respond directly to the students and the participants, I would say participants in this process, has been enlightening, and I'm certainly learning a lot from the people who are responding, writing their stories, and telling us about what's going on for them in their countries. So thank you for the opportunity.
Thank you, Suellen. And now we'll hear from Lenka, her reflections.
I might just echo some of the themes that have already been raised, but I think I have been away over the past 5 days at a conference in South Africa, and I haven't had a chance to engage very much with the comments, but I looked today, and actually all of you have commented on each other's comments so much that I don't actually have anything to add. There's just been a stream of questions and answers and engagements, which is amazing to see, and what that has underlined for me particularly is that the country level experience that you all bring, the context specific examples and cases, can be very rich and very engaging for learners and participants from all over the globe, and this in-depth unpacking of the dynamics, such as, for example, what Oona raised is training midwives and engaging them in being the first providers for care in situations where doctors basically own the labor ward, can be very difficult. So how do we understand the process of this on a country level? Or, for example, how do we understand bypassing, where women are not going to the first facility that has maternity care, but are going to other facilities, perhaps further on or more expensive, that has been raised by participants from India and from Nigeria. So unpacking an in-depth and contextual understanding, this is what you are helping us understand in light of the global issues raised in the series. So thank you very much.
Thank you, Lenka. And if we could also hear now from Oona.
Great. I think the speakers before me have really conveyed the sense of enthusiasm we have about you as learners and the great and stimulating discussions you've been having, and also the ways you've been interacting with each other. I think I want to take us back a little bit and give you a sense of the context. So in 2006, Wendy and myself were involved in a Lancet series, and it was a series on maternal survival. So it was a narrow series, and most of the lead authors in that series came from the London School of Hygiene. And when we had the opportunity 10 years later to revisit this, we were really clear that we wanted to do something that was different. And I think the first thing that we wanted to do that was different was to not just focus on mortality. So rather than having a series on survival, we wanted a series on health. And I think we very much had that much broader vision. And we came up, for example, if you see in our first papers, we're looking not just at mortality, but also at morbidity, not just at the direct causes of maternal mortality, but considering all the indirect causes. But also, I think a theme that comes out very strongly is this isn't a focus just on women with complications, but that we want to look at and appreciate normal birth. We've encouraged, and women have responded. They've come in, and they're with increasing numbers now delivering with skilled birth attendants. And so we need to really respect that and make sure that when they put their trust in us, that they get good quality care. The other thing we wanted to do was we wanted to have a series that was universal and that didn't just focus on low and middle income countries. And that's because we understood that we have a huge amount to learn from high income countries, but also that high income countries have things that they can learn from low income countries and middle income countries, that we need to really understand the context in which women are giving birth before we can start really making the most of all the human resources that we have all over the world. And we also wanted to look very much at scale. We wanted to look at programs that were working nationally. We didn't want to look at small little interventions or pilot studies. But one of the big challenges we faced, and we faced in the series, so the series expanded from just having authors from the school. We had authors from many other academic institutions, but we very much recognized that one size doesn't fit all and that we needed context-specific information. And one of the challenges was, how do you do that in a series when you've only got 5 or 6 papers? And this MOOC, I think, is partly a result of that, but also a result of wanting to reach out to a new generation of researchers and activists and people who are engaged in maternal health. And I think we're really pleased that this MOOC is one of the culminating activities and sort of one of the legacy activities of the series. We've talked about how, and I think Wendy, and the other, just the last point was we wanted to very much articulate that we weren't just going to look within the health system, but in the various ways in which maternal health interacts with other aspects of health, but also, and that's what's really coming up in the last week, as well as some suggestions on how we can all work forward to accelerate progress in maternal health. So thank you very much for bringing back a sense of excitement, and we hope you're inspired by the course to go on and make women's lives better. Thanks.
Thank you very much, Oona. So thank you very much for joining this live Q&A, whether you're joining live or you're looking at the recording of it. We hope you've enjoyed the second week of the course, and next week will be the third and final week, which looks at the future of maternal health. And you've had a couple of tasters today about what that will entail, but mainly it's about being in the SDG era and the future in terms of lots of the big kinds of things that may happen in terms of innovations or external shocks, and also more about the action plan that the 6th and final paper of the series talks about. For now, I'd like to thank you and also remind you that we do have a separate website, which is maternalhealthseries.org, where you can access a number of supporting materials, including videos, infographics and case studies that really bring to life the key themes of the series. And for now, we'll say thank you and good luck next week, and we look forward to your continued engagement.